This timer and here is the question. Right, if you have read and understood, kindly begin your history taking.
Hello,
Hello,
good morning.
morning.
My name is Dr. Ishfaq. I'm one of the doctors working under this Mr. Man. Today, I have been asked to ask you a few questions about your condition. Will that be okay for you?
Yes, please.
Okay, great. So, can you please tell me your name and date of birth, please, before you proceed?
My name is Sarah, and date of birth is 12th of December 1960.
Okay, Sarah. Nice to meet you, Sarah. So, can you please tell me how can I help you today?
I have this back pain going on from can't remember for how long now, and it's just bad.
I'm really sorry to hear that out. Can you please tell me exactly where is the pain? Can you point out the site exactly where is the pain?
In my lower back.
Okay, all right. So, do you think the pain is going, towards your legs, towards the thigh, buttocks, legs, or
Um,
upwards?
it does come in my buttocks, but that's it.
Okay, okay, okay. So, do you think there's any particular time of the day that increasing or it is decreasing as the day proceeds? It is increasing, or anything which makes it better, which makes it worse?
It's just there all the time. Nothing makes it better. Nothing makes it worse.
Okay, all right. So, if you have to rate the pain from 1 to 10, 10 being the most worst unimaginable pain you have ever experienced, how do you rate it?
Uh, 7 to 8.
Okay. So, Sarah, do you think the pain is affecting your daily activities and the life?
Yes, doctor, I can't. I have a husband who I look after, and I can't
Right.
do it.
Okay. I can understand, appreciate your concern. So, Sarah, can you please tell me, have you experienced any trauma recently?
No, no trauma.
Okay. Any fevers, any stiffness of joints recently?
No,
How has been your appetite?
it's all right.
Have you experienced any unintentional weight loss?
No,
Okay, so do you think you have been experiencing or you have observed any weakness in your legs, any abnormal sensations, pins and needles in your legs, or in your buttock area, in your lower back?
answer to all these questions is no.
Okay, all right. So, have been investigated before for this back pain?
Yes, yes, I was told that I have arthritis in my back.
Okay, and what has been done for that?
Nothing.
All right. So, is there anyone else in your family who has been experienced the same problem or who has experienced the same problem before?
No,
All right. Okay. Do you have any other condition you see your GP for?
no,
Okay. Are you taking any medications?
no. I just take paracetamol for back pain.
All right. So, have you any allergies?
No,
Okay. Have you been operated before for any condition?
no,
Okay. Have you been to abroad recently?
no.
Okay. All right. So, can you please, do you mind if I ask you some few personal questions?
Yes.
Okay. Can you please tell me what do you do for a living?
I am a librarian, but
Okay.
I work part time because I have a husband to look after.
Okay. Apart from your husband, who is at home with you?
No one. It's just we two.
Okay. All right. Okay. Do you smoke cigarettes?
No,
All right, good. So, do you drink alcohol?
no,
Any other recreational drugs?
no.
Okay, all right. Have you experienced any pain in the joints, any muscle pain, any shortness of breath, something like that?
Oh, well, I'm getting old now, so yeah,
Right.
joint pain is like not some you would expect some
Oh,
sorts, but nothing else.
right. All right. So, how has been your waterworks and your bowel movements? Any issue with that?
Nothing concerning.
Okay. Have you had any fractures in the past to any of your bones
No.
that I should be aware of? Okay. Is there anything else you would like to tell me that I haven't asked you from your side?
No. You probably asked me everything. Just tell me what's wrong with me.
All right. I will get back to you. I will discuss my case with my consultant and then I will get back to you. We'll discuss everything. Okay, Sarah?
Yeah, that's fine.
Okay. Thank you. Thank you very much for your time, Sarah. Thank you. So today I have asked.
Have you asked the expectation ice?
Sorry, I forgot to
Yeah.
say the ice.
So they are also
So if
telling
I
you.
have time, I can.
You have 1 minute. Ask quickly.
Okay. Sorry. I need to ask you a few questions more. So, what do you think? What might be causing your problem? This, back pain.
I don't know, doctor. I'm just worried about it. It was. I know I have arthritis, but this pain has gone worse now. So I don't know. There's something has changed.
Right. So this is your biggest concern, or do you have any other bigger concern than this?
Well, this. It is affecting my life, so it is my biggest concern. I need something sorting out for my
All
back.
right. All right. So what are you hoping us to do for you when you have been, yeah, you came to us today? You must be having some expectations as well.
Just tell me what's the cause of my pain.
Okay, for that I need to
Okay.
discuss this case with my
Now,
consultant. We may need to run some tests and I'll get back to you. Thank you very much for your time. And
yes.
today I asked a history from a 54-year-old gentle
Yes.
lady, Sarah, who has come to our OPD with the complaints of back pain from the last 5 years. Has
Yes.
been worse from last 3 years. Pain is in the back and it is radiating to the buttocks as well.
Yes.
There is no aggravating or relieving factors. Pain is around 5 to 6 in the rate from 1 to 10.
Yes.
And the patient is not complaining of any weight loss, any fractures, any trauma in the past. There is no positive family history. Patient is taking paracetamol occasionally, no other medication, no other medical history.
So
And
what
the
is your
patient is.
differential diagnosis?
So my differential diagnosis will be the functional back pain,
Yes.
and I would also like to rule out other causes of back pain like prolapse, intervertebral disc, spinal canal stenosis, any osteoporosis, rheumatoid arthritis, ankylosing spondylitis, and osteoarthritis as well.
Very good. Okay. How do you plan to manage this patient?
So after thorough history and examination, I would like to
Yes.
do some blood investigation in this patient, like full blood count, LFTs, KFTs, markers for inflammation, ESR, CRP, rheumatoid factor, and yeah, markers for ankylosing spondylitis as well. I would like
Yes.
to go for an X-ray of the lumbar spine, AP and lateral view, and maybe if required, we can do the MRI lumbar spine
And what should
if
be
needed.
the treatment?
So I'd like to discuss this case with my consultant and the orthopedician. And after that, we have few options like we can manage the patient initially conservatively by giving the pain medications, following the W2 later protocol, then advise some good physiotherapy exercises, refer to some physiotherapist, and avoid prolonged bed rest. Uh, Ask patient to lose some weight, remain active, and if that does, then we may need to go for some invasive procedures like operation. We may need to go for laminectomy, disectomy if needed,
Very good.
or intra-articular injections as well, steroid
Excellent.
injections.
Yes. Excellent. Well in time. Everything in time. Very good.
Thank you, man. I
Yes.
skipped this. I sorry.
You skipped what? You forgot. But
Yes,
then
yes,
you
I forgot.
remembered and you covered it within time. So
Yes, yes.
that's yeah, that's great effort. And
Thank you,
now
man.
you are coming. One more time we'll do history taking and then we'll do
Yes.
something else. And here is the question. Once you have read this, tell me, I'll change it. Next page.
Yes, ma'am.
Right. So if you have read and understood, kindly tell me, considering age critical care scenario, how would you manage this patient?
Then I'll be managing this patient according to CRIS protocol. Make sure the patient had adequate airway, breathing, and all. After all that, I'll make sure the patient had 2 large IV bore cannula. Hydrogen has been started because the patient tachycardic and hypotensive, and along with the patient tachypneic. And meanwhile, I'll send the blood for cross match and certain baseline, which starting from the CBC, UC, LFT, PTNR, serum amylase, lipase, serum albumin, and serum RBS, AST, ALDH.
Okay. Can you tell me what is your differential diagnosis for this patient?
Ma'am, my diagnosis is acute pancreatitis, acute cholecystitis, or either a cholangitis.
Can you tell me what are the causes of acute pancreatitis?
Ma'am, it could be so many things. Starting from it could be secondary to gallstone, secondary to alcoholism and trauma. Could be hereditary. Could be secondary to autoimmune diseases. Secondary to certain viruses such as the Coxsackie and mumps virus, and could be
What
due
are
to
the
the
drugs?
scorpion bite.
Yes, what are the drugs which cause
Ma'am,
acute
drugs could be
pancreatitis?
starting from the estrogen to corticosteroid, ethoprin, and could be even thiazide diuretics.
Okay, good. Can you tell me what is the pathogenesis
Ma'am,
behind
it
all
is
this condition? Yes.
Ma'am, it could be multifactorial starting from if there's any obstruction in any way down the CBD and the pancreatic duct that would lead to the reflux and stasis of the bile, and these three reflux will go inside the pancreatic duct and leakage of the enzyme which got activated and lead to the autodigestion of the pancreatic parenchyma. Second thing would be the release of the lipase in the circulation can lead to saponification, and along with that could be the release of elastase into the blood vessel, and they could lead to the hemorrhage. And these all are the pathogenesis for the acute pancreatitis.
Okay, good. Can you tell me how would you diagnose or confirm your diagnosis clinically?
Okay, ma'am. First of all, there could be certain blood investigation and other radiological investigation. In blood investigation, amylase or lipase should be 3 times the normal, and along with
Are there
that,
any
if you
criteria that you are going to follow
yes,
or
ma'am,
confirm?
there are yes, ma'am, there are two. There are 3 criteria. Do on the basis of clinical investigation. The other on the basis of radiological investigation. In clinical, we have FIT, and we have the Glasgow, and along with that, we have a Rensons. And the one on the basis of CT scoring, the Balthazar scoring.
Can you tell me about the Renson's criteria both on admission and after 48 hours? How
Yes,
would you
ma'am.
differentiate them? Yes.
Yes, ma'am. On admission, there are basically five things. Each one has been given a score of 1. Like if the patient having the TLC of greater than 16 per cubic micrometer, age greater than 55, and glucose greater than 200, and AST greater than 250, and LDH greater than 350. If all of them are above this normal range, it has to be given a 1 to each. And talking about the 48 hours, it would be having a study with the fall in hematocrit more than 10%, and increase in bun greater than 5 since the admission, and fluid sequestration greater than 6 liter, PO2 of less than 60 millimeter of mercury, and bicarb deficit greater than 4 millimoles per liter.
This patient is tachypneic. Can you explain why?
Yes, ma'am. Well, there could be so many things, starting from it could be systematic manifestation. There could be ARDS, which could lead to the tachypnea, and the second could be a pancreatic swelling and edema that lead to the splinting of the diaphragm, and leading to leading to the overdrive of sympathetic nervous system, leading to tachypnea.
Okay. Can you tell me why the patients with acute pancreatitis can have hypoglycemia? Hypocalcemia, sorry. Hypocalcemia, yes.
Sorry, I just got unmute. Ma'am, it could be multifactorial, starting from either there's saponification because of the lipase release, causing the chelation of calcium to the free fatty acids in all fats in the peritoneum. Second, it could be a direct damage to the parathyroid and leading to the decrease in the parathyroid secretion.
So if you don't manage patient with acute pancreatitis, what are the complications that you should expect?
Ma'am, there are multi complications starting from the local to the systematic. Local are the complications that occur after some weeks, and the systematic complication occur very early. Starting from the scene, it could be the confusion and lower GCS. It could be a shock, arrhythmia, and there could be a hemorrhagic shock, and there could be the ARDS and DIC, ARF, DIC, ARF, and then local it could be acute non-infective peripancreatic accumulation, infective accumulation, pseudocyst, pancreatic abscess, necrosis, and splenic vein thrombosis and portal vein thrombosis and CVD stricture later on. And if there's a stone or there's been a repetitive inflammation over there down there.
Okay, one of the complications you have mentioned can be pseudocyst. Can you tell me what are the components of pseudocyst?
Ma'am, it is basically a very well circumscribed accumulation of amylase-rich fluid surrounded by a fibrous tissues.
How long would you wait until you suspect that patient can have a pseudocyst?
It can occur within 4 to 6 weeks after the first attack of pancreatitis.
What blood test would you do which will make you think or
Serum
suspect
amylase,
will be high?
serum
Okay.
amylase.
And how the patient will be presenting?
Ma'am, they would be starting with certain signs and symptoms. The patient will be having complete nausea, vomiting, abdominal distension, and there could be a mass on the center in the epigastrium and
Okay.
dyspepsia as well.
How should pseudocyst be managed?
Ma'am, it depends. Like if it's less than 5 centimeter, if it's asymptomatic, you can manage it conservatively. You can give it the trial of 6 weeks to give it time to resolve spontaneously. If in case gets enlarged, or if it's a thick wart and it remain persistent or asymptomatic despite of being a simple cyst, in these particular scenario, you might go for certain invasive procedures, or if it's infective.
What are the complications that you should expect if you leave the pseudocyst untreated?
Ma'am, Ma'am, the cirrhosis can undergo. It can first get enlarged. It can get infected. There could be a hemorrhage, and there could be a perforation of it inside the peritoneum or inside any of the bowel wall, and there could be a rupture of the cirrhosis as well.
Okay, good. Can you please tell me how would you go about and manage the pain for this patient?
Ma'am, basically what we usually follow is a WHO pain ladder pathway, but in this patient
Yes.
we won't be giving the NSAID and morphine. We rather giving the pethidine and maprodine.
Okay. Can you tell me how would you tell if patient has been taking paracetamol overdose? How would patient react or how would that lead to liver injury?
Then there are certain toxin metabolite of paracetamol, such as NPQD, and this is basically neutralized by the glutathione, which is an antioxidant in the body. If it's get bit more than the already reservoir of the antioxidant in the body, that will lead to the accumulation of that toxin metabolite and leading to liver toxicity.
Okay, good. Can you tell me how would you think of managing nutritional requirement for this patient?
Ma'am, nutritional requirement, there are two school of thought. One says in a mild and moderate, you can start the patient on the nasogastric or nasojejunal feeding as soon as you can. Some says do not start it, go with the TPN, because more you give the fluid through the enteral pathway lead to the activation of the pancreatic enzyme. So
All
you
right,
can give
good.
it TPN in the severe cases.
Okay. All right, good. I was going to ask you the last question. Would you or would you not consider giving antibiotic to the patient with acute
Ma'am,
pancreatitis?
Ma'am, there again two school of thought. Some say in mild cases you do not need to give the antibiotic. If it's a severe
Yes,
case, this you can give, and these antibiotic can be ranged from starting from second generation cephalosporin, such as cefofuroxime, to the imapinum and fluoroquinolones.
very good. Excellent.
Thank you,
Excellent.
ma'am.
Yes, good. Yes, started the timer and here is the question. Right. So if you have read and understood, let's begin our session. What are you looking at, please? In picture A and in picture B.
I am looking at the right foot osteotomy. I mean,
Okay.
bones of the right foot.
Yes. Would you be able to identify this number 9 pointing at
It's
the
a
narrow?
head of the talus bone.
We'll revise at the end. Okay, number 18, please.
18.
Here in picture A.
Tentaculum tali.
Okay, and yes, number 9. What did you say? Lateral tubercle of talus.
Lateral tubercle talus.
Okay. Right, 16 here, please.
Neck of the talus bone.
Very good. 21,
It's navicular bone.
tuberosity of navicular. Okay, 10, please.
Medial cuneiform.
Yes. Okay, here 19 in picture B.
That's calcaneum. No, that's not
Dorsal sinus.
tarsal sinus. Okay.
What's the importance of this?
Tarsal sinus.
Yes, importance. Okay, number 2. We'll come back to that later. Number
Okay.
2.
Cuboid bone.
Yes. Number 8 over here.
It's again calcaneum. Tuberosity or something.
Lateral process of calcaneus. Okay. 12 number 12 in picture
Medial
A.
tuberosity of calcaneum. So medial process.
Medial process. Yes. Okay. All right. Moving ahead. Can you identify these circled ligaments?
Is it a ligament or the retinaculum? Deltoid ligament. Sorry, it's a deltoid ligament. Yeah.
This circled one.
Yeah, it's a deltoid ligament. It is in talocalcaneal ligament.
Deltoid ligament. 26,
Yeah.
please. In picture C. 26.
It's a talonavicular ligament.
18, please.
Again, it's a part of the deltoid ligament. It's a calcaneal. No, it's not talonavicular or something.
Okay.
Talocalcaneal part.
Number 1, please. In the picture below. No cheating.
Is it anterior
Talofibular ligament. Very good.
talofibular ligament? Okay.
Number 3, please.
Posterior talofibular.
Calcaneofibular ligament. Okay. This number 3 on picture E.
It's again the same, isn't it?
Yes. 19, please.
It's from the medial mal going to, is it?
Okay. Now, please tell me. Can you please tell me how many arches there are? How the foot is supported?
We have 3 arches: medial, lateral, and transverse.
How are they formed?
How are they formed? They are formed by the ligaments, bones, and the muscles.
Yes, please explain. Which arch is formed
Hello?
by what and yes?
Sorry?
Which arch is formed by what? If you can tell me the details, please.
Oh, okay. Medial arch is formed by calcaneum, talus bone, then navicular 3 cuneiform bones, and medial 3 metatarsal bones. The ligaments involved are the spring ligament and talocalcaneal ligament. Muscles involved are the tibialis anterior, peroneus longus, and tibialis posterior. Then we have lateral arch, which is formed by calcaneum, cuboid, and lateral 2 talus bones.
Metatarsal.
Lateral 2 metatarsal bones. The introitious ligaments are involved, and the muscles involved are the lateral muscles, lateral compartment, which are peroneus longus and brevis. And transverse arch is formed by the introitious ligaments and heads of the all 5 metatarsal bones.
Okay.
And muscles involved are the tibialis anterior and flexor longus.
Okay. Can you please tell me what is the attachment of deltoid ligament?
Deltoid ligament consists of 2 parts, superficial part and the deep part. Superficial ligaments consist of tibionavicular ligament, tibiocalcaneal ligament, and deep consists of anterior tibiotalar and posterior tibiotalar ligaments.
Okay. Can you tell me what are the movements which are present at subtalar joint?
If the basic movements are inversion and eversion of the joint.
Okay, can you tell me which muscles perform these actions?
Eversion is performed by the muscles of the lateral compartment, which are peroneus longus and brevis, and the inversion is performed by the tibialis anterior and posterior.
Okay, good. Can you tell me what type of joint is subtalar joint?
It's a hinge joint so of the synovial.
No, ball and socket type of synovial. Okay, what are the bones forming the ankle joint?
Ankle joint is formed by the distal end of the tibia and the fibula, along with the.
And what type of joint is ankle joint?
It's a hinge joint
Yes,
of
synovial
synovial
hinge
joint.
joint.
Yeah.
Okay, ankle joint, they say, is most stable in dorsiflexion position. Why?
That's because of the shape of the talus bone on the tibia. Talus bone is more widened anteriorly, so when it is in the dorsiflexion, it fits exactly with the tibia. That's why it's more stable in that position.
Can you tell me if there is syndesmotic fracture, then what are the type of associated injury that you can find?
We can have type of associated injury with the
Yes,
syndesmosis. We can have lateral or medial
malleolus.
malleolus fractures.
Yes,
It can be
very good.
bimalleolar fracture or it can be
Yes,
traumatic fracture.
yes. Okay, can you tell me what muscles make up Achilles tendon?
Achilles tendon is made up of gastrocnemius, soleus, and plantaris.
Okay. What are the structures passing behind the medial malleolus?
The structures passing behind the median malleolus from anterior to posterior are tibialis posterior, flexor digitorum longus, anterior to posterior tibial artery and vein, tibial nerve, and flexor hallucis longus.
Okay, can you tell me what are the muscles involved in dorsiflexion of the
In
foot?
dorsiflexion, we have the anterior compartment, which includes tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius.
Okay, what do you understand by the term mid-tarsal joint of Chopard?
Mid-tarsal joint of Chopard.
Yes.
I don't know, sorry.
Okay. Can you tell me what are the movements, or how would you describe walking?
Walking has two phases. One
Yes.
is the stance phase, and the other one is the swing phase.
Yes.
So in the stance phase, the foot is on the ground. For the hind foot is on the ground. Then in the swing phase, it is up, and then in the stance phase is again the hind foot is on the ground. Then
Okay.
yes.
Bell has gone, but I just for the sake of fun, I have one more diagram. Can you please explain what are you looking at number 6? This?
Is it has extensor brevis muscle? I'm so bad with these things. I can't identify
Yes,
pictures.
we have to practice.
It's
That's why we're
extensor hallucis
practicing.
brevis.
Is that it? Okay. And number 12, please.
Uh, no idea. Sorry.
Okay, 17. No,
Seven.
12. It's 12 here, so it's the same 12. All right, and number 5, please. Here.
Extensor digitorum longus.
17 over here.
Uh, that's
Which foot
on
is
the
it? Which foot could that be?
right.
Okay. All right, and I'm going
It can be
to
tibialis
just.
anterior. 17 should be tibialis anterior.
Okay, 7.
Extensor hallucis longus.
Okay, now we'll revise. Okay, now we will revise. 17 is tibialis anterior.
Yeah.
Okay,
So yeah,
right?
tibialis anterior. Yeah.
And then number 6 was extensor hallucis brevis. See,
Yes.
small muscle. And 7, I asked you, 7 is extensor hallucis longus.
Yeah.
5, I asked you, extensor distrum longus.
Yes.
Okay. Maybe we can see where does it inserts
Yeah.
each phalanx, and then we can.
What was 12?
And 12 is posterior fibula, peroneus tertius.
Okay, that's the base of the.
Peroneus tertius. This is
Okay,
that one. Okay. And which other one I asked you?
that's about it.
Yeah. Okay. All right. All right. Let's end here. But there are still many questions that could have been asked. But okay. Yes. Thank you so much.
What was
We'll,
tarsal sinus? I forgot that thing.
yes. Tell me. Who would tell? Dr.
Which one,
Abhishek?
ma'am?
Tarsal
Yeah, which
sinus.
one?
The importance, significance of it.
Okay, tarsal sinus actually formed by three arteries, anteritibial, posterior, and the peroneal artery, and it gives blood supply to the tarsal bone. So whenever there may be some injury or something like any disruption of the blood supply, due to this sinus pattern, there is more chance of avascular necrosis of the tarsal bone actually. That's the importance as far as I know, ma'am.
Yes. The rest will read.
Yeah, ma'am.
That's the purpose of revision. We should take some homework with us. Go back home and we should read. Thank you so much. Thank you. Good. Yes. Started the timer and here is the question. Right. If you have read and understood, kindly begin your examination.
After entering the room, I'll wash my hands and introduce myself to the patient and confirm the name and age of the patient.
Yes.
Then I'll take the permission from the patient to examine his gland or swelling over the face, and also examine the other area of face and neck. That would include the looking, feeling, and listening. I'll request the patient for the exposure, which will be up to the neck area by putting down the gown or opening the two buttons of the shirt or t-shirt. I'll help the patient for the same. Now I'll examine the swelling. I'll start by taking a close look to patient's face. Then I'll ask the patient to clench his teeth, and then I'll inspect bilaterally the parotid area, first from the front and then from both sides. And I'll look for any the site, size, shape, surface, any scars or condition of the overlying skin. And I'll also examine the facial nerve branches to see if there is any involvement of the facial nerve by asking the patient to look. First, I'll ask the patient to look to the roof without moving the head up. And then I'll ask the patient to close the eyes, and I'll ask him not to let me open them. And then I'll ask him to blow the cheeks, then show me the teeth, and finally tense the neck muscles. After that, I'll ask the patient to open his mouth, and I'll inspect the Stenson's duct, which is present opposite the upper second molar tooth. And I'll see the opening either by using the tongue depressor or by using the patient's own finger. Then I'll take the permission from the patient for feeling the glands and face. I'll feel the both side of the gland bilaterally from the behind. I look for the tenderness if there is any. I'll ask the patient if he has any pain or not, if he needs any analgesic. Then after that, I'll see the temperature with the back of my hand if there is any temperature or not. I'll see the margin or of the gland. Then I'll see the consistency, whether it is firm or it is hard or firm or nodular. Then I'll look for the surface of the swelling, if it is regular or irregular. Then I'll see the pulsatile, if it is not pulsatile or not, if it is compressible or not, if it is cystic or not, or any reducibility or present or not. Then I'll see do the skin pinch test to see if it is attached to the superficial skin, or if it is mobile or attached to the deeper structure. After that, I'll also from the behind do the pre-auricular, post-auricular, and cervical lymph nodes examination. And then I'll go for the bimanual palpation by asking the patient to open the mouth. First, I'll explain what I'm going to do, and then I'll do this examination by wearing the gloves and feel inside in the vestibule with the help of my one hand, index and middle finger, over the vestibule of the cheek, and another hand will put over the gland outside, and then I'll feel if there is I can feel the deep lobe or not, and then I'll also feel the extensions duct for any stone. After that, I'll measure the size of the mass using the measuring tape, and then I'll try to do the trans illumination test by asking the examiner to dim the light, and then I'll use the torch and the cone to see if there is any trans illumination test. Then finally, I'll auscultate to see any bruit present over the lump or not by the use of cone of stethoscope. And after that, I'll ask the patient if he needs any help. Otherwise, I'll thank the patient and ask him to cover his neck, and then I'll wash my hand. So to complete my examination,
would you? Yes.
To complete my examination, I'd like to examine other salivary glands also, and I'll try to do the ENT examination.
Okay, what
So
about the
today
same
I've
examination on the healthy parotid gland?
Yeah, I also did the examination on the opposite side,
This you
all
have
the
to
examination
mention.
on the
Yes.
opposite side.
This you have
Yes,
to
I've
mention while explaining.
yeah, I have to examine opposite side also. All the examinations
All
what
the
I've mentioned, I
you have
do.
to carry
Yeah.
out on the other side as well.
Yes.
So which side would you examine first, healthy side or the?
I'll examine first on the healthy side, and then
Yes.
I'll compare this on. First, I'll examine on the left side, which is the healthy side in this
Yes.
patient, and then I'll compare with the right side, which is he has the swelling.
Swelling.
So yeah.
Okay. Yes.
So
Can you present your case now?
yeah, so ma'am, today I examined a 56-year-old male who
Yes.
presented with swelling on the right side of his parotid region, which is about 2 centimeter into half centimeter in size. It is oval in shape. The surface is nodular and the margin is well defined. The swelling is firm in consistency. It is mobile, it is non-tender, there is no pain, and there is no pulsatility present. It is not compressible and not reducible. It is free and not attached to the skin or any underlying structure, and there is no any associated lymphadenopathy. Also, the extensions duct is free of any inflammation, and there is no stones felt there. The saliva secretion is clear, and the facial branches are completely free. And
Okay.
also on bimanual examination of the floor of the mouth, I cannot palpate the deep lobe, and the trans illumination
yeah.
and test was negative.
So
And
what are
no
your
audible
differential
growth.
diagnosis of the lump?
My differential diagnosis will be the parotid gland tumor, most probably the pleomorphic adenoma.
Okay. So what else are you going to keep in your mind?
I will also consider about some infective pathology like parotitis or some inflammatory pathology
Yes.
like Sjogren's syndrome or
Yes.
Mycosis syndrome. And there will be other tumors like benign tumors other than pleomorphic adenoma. There will be Warthin's tumor also, or
Yes.
and malignant tumor like mucoepidermoid carcinoma, adenoid carcinoma, even adenocarcinoma, or generalized like lymphoma.
All right. How would you confirm your diagnosis?
I'll confirm diagnosis by doing the mainly MRI to extend the area, and whether it is involving any bone or any surrounding structures like nerve. Then we can also do the ultrasonography, or we can send the fine needle aspiration cytology to confirm that what type of cells it is.
Very good. Okay, what should be the management for the patient?
Management will include, ma'am, only surgical, that is superficial parotidectomy.
Okay, can you tell me what is the percentage when patient presents with parotid stone, when there is duct obstruction and the cause is stone?
Percentage, I think it is, I don't remember, I think 5 or 5%.
Okay,
I
what
don't
is the
remember. To be,
prognosis of
I'll pass this.
pleomorphic adenoma?
The prognosis of pleomorphic adenoma is very good. It does not usually involve the facial nerve or any other structures.
Very good, and it's benign.
Yeah, it
That's
is
why.
benign
Yes.
tumor, so its prognosis is very good.
Very good, excellent, good. You covered within the given time and you covered everything. So one thing you have to remember, you have to do each step on the contralateral side as well.
bilateral side, yes.
Mention it like clearly
Yeah,
so
yeah.
that they know. Okay,
Yeah.
very good.
And what the last question you asked, ma'am, percentage, I don't know what percentage of this
Dr. Abhishek is saying
extensions that.
20%.
It's the percentage of stone formation in the parotid gland,
Yes.
Dr. Suman.
Okay.
What are the
Okay.
chances? Like
Causing
mostly it occurs
obstruction.
in the submandibular, yeah,
Mostly there, yes.
Okay.
more
Yeah,
than 60%.
now I remember I read it most probably in pathology station.
Yes.
Okay.
Yes.
And yes,
Yeah. Now I
you
remember
had the
actually.
time, so I asked you one extra question. So that's why.
Yeah, it's good, ma'am.
Yes, even contribution to salivary gland is less than submandibular gland.
Yes.
Very good. Okay, excellent. You should be happy with yourself.
Thank you, ma'am.
Yes, submandibular is 80. Very good. Yes,
Yeah.
excellent. Here is the question. Right. If you have read and understood, kindly begin your.
Yes. Okay, I'll enter the station and then I'll introduce myself. I'm Dr. Nadeem, one of the surgical candidates. I'm calling, so I want to call to ICU registrar. May I please confirm whom I'm talking to?
Yeah, I'm Mr. David, ITU registrar.
Okay, Dr.
Why
David,
did you call me?
thank you.
Yes.
Nice to talk to you. Can I please take few of your moments? I have to discuss a patient, 76-year-old lady.
Okay.
Is that right with you now?
Okay, you summarize the case.
Oh.
Yeah, it's okay. You just summarize the case.
Okay. Thank you. So it's a 76-year-old lady who has been brought to emergency with a complaint of sudden onset of abdominal pain, and moreover, she is also feeling drowsy, and she's a known case of COPD, and for that she has been taking steroids. So that is a thing to be kept in mind, and her labs are still latent, and she requires urgent laparotomy considering the examination of her abdomen and the vitals at the moment. So I would like to take your suggestion as to how to transfer the patient.
Why do you want to do this urgent laparotomy? I mean, what you are thinking it is?
So, sir, as I mentioned that there was sudden onset of pain, which is not being relieved, and it is increasing, excruciating, vitals are not normal. She is tachypneic, tachycardic,
Okay,
temperature is high.
Actually, I want to know what diagnosis you are thinking about for this pain
So on
abdomen.
X-ray, if I found a gas under the diaphragm on X-ray, it's leading to perforation, to
Okay.
intestinal or gastric
Okay.
perforation.
So, do you do fluid resuscitation to this patient? What did you give or will you give?
Let me check exactly, but definitely the patient has been started on initial resuscitation. But for exact details, I'll
If
have
you
to check
have
that
to
that
do
it is.
if you have to do fluid resuscitation, what will you do?
Well, I'll start with the normal saline initially, 1 liter bolus, and looking for the response of the patient. And I'll start with ABCD protocol, in which I look for airway, breathing, and circulation. I'll apply non-breathable mask oxygen. Initially started at 5 liters and increasing it gradually to 10 liters or even 15 liters as required, and also looking for any problem with
Do you need
breathing.
any blood?
Yeah.
Do you will give any blood to
Yes,
this?
and after that I'll pass the cannula, wide bore cannulas to cannulas, so as to start the immediate resuscitation with the IV fluids and boluses, and also take the bloods for complete blood picture, serum electrolytes, RFTs, and LFTs, and CRP, sorry, and blood cultures
Okay,
in
doctor,
this case.
you are taking the patient to OR, operation theater, for urgent laparotomy. So before taking that, what pre-operative arrangement will you do before taking the patient
Okay.
to operation theater?
Okay, I'll follow the labs. I'll take you in the ITU team in liaison, and I'll also inform the manager of operation theater for keeping the list updated, and also call my consultant and the anesthetist in charge for anesthesia fitness.
You know the patient is a case of COPD, so will you do anything for that also?
So for that, I'll need to, as it is a high risk surgery, a major surgery, and the patient is on steroids, I'll need to know the dose which the patient was taking. If it was more than 5 milligram per day and taken within last 2 to 3 weeks, then we'll give 50 milligram at induction, and then uh, 50 milligram TDS for next 48 hours to 72 hours, and tapering it off.
Okay. Doctor, you called for ITU bed. So can you tell me what are the criteria for admission in ITU?
So if there are two systems failing, or one system is failing chronically debilitated with one failing, or if there is need for ventilation or need for inotropes or circulatory one-to-one monitoring or major surgery, then we need ITU.
Yes, so you can you tell me how many types of oxygen mask, which type of oxygen mask you use for COPD patient?
So we will use venturi mask, and we will keep at 2 to 4 liters to keep it the oxygen saturation at oxygen ratio at 24 to 28%, so that the patient does not lose the drive for oxygen.
And how will you calculate the potassium deficit?
So potassium deficit for every 0.3 milliequivalent loss. For example, if it is 2.5, then from 3.5 it's almost equal to 300 milliequivalents. So we will replace that slowly, not replacing more than 50 MEQs in 5 hours.
Okay, so suppose if I have only one ITU bed left and there is one asthmatic patient, young lady coming first, he called me first.
Okay.
So what will you do then? I have no
So
bed
I'll
for
sir,
that.
after the operation, I'll follow the patient. I'll be watching for the vitals in the post-operative recovery, and till the patient or another bed is available. For example, after downstaging of the ITU patient to HD or ward, I'll be waiting for that.
Okay. Okay, doctor. I'll
So
see if
I needed some of I needed some of your
If you-
suggestions. Kindly, if you can give me a few suggestions
Yes,
so that I can follow them too.
yes. Actually, right now there is nothing I can give you. Just go for the surgery. I'll try to put the
Okay,
date
sir.
for you. Okay. So
Okay.
that's
Should I
okay,
call you,
madam.
sir, anytime?
You summarize the
Yeah,
case.
yeah. If you can summarize the case finally
Yes.
before you leave,
Okay.
just
So,
summarize all the thing.
okay,
All the
I'll,
discussion that
I'll,
has been, yeah.
yes,
Yes. Oh,
right, sir.
yeah.
So I'll follow this ABCD protocol and follow also the, give the IV fluids, boluses, and look for the urine output as well and the vitals, and informing the anesthetist, my consultant, and then also looking for this steroid dose adjustment at induction and after surgery, and not also keeping in liaison with you, the ITU team, uh, to bring the patient to ITU whenever the bed is available, and also informing them of the updated labs and vitals. Is that okay, sir? Did I
Okay.
miss
Okay,
something?
doctor. Yeah. No. Okay.
Thank you so much, sir,
Okay.
for the guidance. Thank you.
Okay.
Good. 2, 3.
Yes.
Very good. All right. Very good. Okay. Now
Yes.
feedback. When
First of all, ma'am,
yes,
I'll tell that
yes,
this one question he has to read, that is the pre-operative arrangement.
arrangement. Yes, I
Uh,
was also going to discuss
yeah.
those.
Yes.
Otherwise, he has the knowledge. I did
Uh,
realize his speed went little low. I don't know why he had so low morale when he was explaining. He should have been hyper excited and with the speed. Yes, that
yes.
he should just tell why, because patient is COPD and taking steroids. You're doing
Yes.
urgent
And one
laparotomy. You
thing.
don't know when patient stops steroids, so you have to prepare the patient. You have to be aware that patient can, in this age, can have arrhythmia. So you'll monitor patient continuously with the
Yes.
ECG. Then you'll do the even repeat the chest X-ray. You'll check if you'll make sure if your patient has taken steroid inhalers. If not, or if patient has taken, then you will have to arrange it IV hydrocortisone, and then you will monitor
Yes.
those closely as well. You'll monitor vitals, you'll monitor oxygen saturation as being patient on COPD, and then you'll arrange even antibiotics and
Yeah.
post-operative chest care like physiotherapy, etc. So
It
this
should
you
be in
have
two
to.
sentences. Yes, I should try it.
Yeah. Yeah. Actually,
Yes,
it's
I
okay.
do
But
agree.
the main thing, pre-operative arrangement is clear
Is
for this
important.
patient.
And
Yes, it
then
is.
Yeah,
did you how much
Oxygen, he told
oxygen
me.
did you tell?
Yeah, he
24
told
to
me.
28.
Yeah, he told that I
What
have
they
to.
say, the FiO2,
Yes,
yes,
Yes.
that he
ratio
told
or
that.
FiO2.
The mask and that one, it
Yes.
together. But I don't know about serum potassium, whether he told you.
That
I
is,
don't know. I have to check.
uh, from what I know, it's zero point 0.3 for every 0.3 MEQ of deficit, you give 100 MEQ, roughly. Like if it is 3.5, the cutoff, and you have 3.2, then you have to replace 100 MEQ.
Okay, in this station, what
Okay.
will happen, because you're calling and you're asking for advice, examiner will make you, you have to write down everything he says or everything you discuss with him, because at the end, examiner will make you repeat everything he has told you before you leave.
Yes.
Okay, and you
Yes.
will be
Yes.
graded on the basis of what you have recalled. Okay, so that's
Yes.
why important. That's why I told you to summarize it, everything you have discussed with your examiner,
Yes.
because in this
Yes.
one you get the marks on that, and this is most probably ruptured viscous.
Yes. That question also,
Yes,
when
he
I
has to
asked
keep in his
about
mind.
this, means why you want to go for a
Yeah,
laparotomy,
yeah.
or the actual question should be that you should mention that I am suspecting perforated viscous. So I should have asked why you are suspecting perforated viscous,
Yeah,
or I asked you in a script that why you are taking the patient for laparotomy. Then you should say that there is presence of peritoneism and
I haven't written
abdominal
yes.
ultrasound.
information,
Paroticism
but
or
there is
air under the
ultrasound
diaphragm.
and there's free fluid in abdomen, and X-ray chest is clear. But I haven't missed I haven't written these information in the stem. That's why he probably missed.
Yeah. That's why
He forgot,
missed it.
yeah. And patient has lost 2 units of blood as well. So when doctor, your consultant asked you about the blood arrangement, that you should keep in your mind as well.
Cross-match blood group.
Yes,
Resuscitation always
cross-match blood as well.
resuscitation. Yes, ma'am. Right. Resuscitation with crystalloids and keep the blood ready.
Yes.
That's the
So
Oh,
you
yes.
have to arrange
Blood,
do the cross
keep the
matching
blood
and
ready and
arrange the
copy.
blood.
Yes.
Yes.
And here Addisonian crisis can also happen. So
Happen.
warming
That's why.
and ECG and
That's
all
why
these
it's
things.
important.
And even looking for BSR because insulin sensitivity is being disturbed in Addisonian crisis. Patient can go into hypoglycemia as well, and shock and all these things, and arrhythmias. Yes,
That's
but
Very
with
good,
practice,
yes.
these things come into mind. Practice
Yeah.
is needed, and some
All right.
gasoline is needed. Dr. Tashaba, from where did you take all this?
And here is the question. Right. Considering it's surgical pathology station, kindly tell me what is your provisional diagnosis?
So according to the scenario, my first provisional diagnosis be it may be a case of enlarged prostate. It may be a case of like chronic cystitis, chronic UTI secondary to enlarged prostate. And it may be a case of prostatitis, or it may be also a case of prostatic carcinoma.
Okay. How should, just suppose, how should this patient be managed?
Okay, so according to the history of the patient, at first I'd like to go for certain investigation like full blood count, ESR level, CRP level, urine dipstick test, urine profile, urine culture sensitivity. And also I'd like to go for after that, I would like to go for a transrectal ultrasound of the prostate, and also I can go for the ultrasound of the pelvic region to know the size of the prostate. And after the test, if there is a case of UTI, I would like to go for medical management for that. And if it is causing chronic UTI or something, a complication of UTI due to enlarged prostate like hematuria, and I can go for the prostatic biopsy. And after that, I can go for if it is the normal normal benign enlargement, we can go for transurethral resection of the prostate. And if it is a case of prostatic carcinoma, we can rule out if there is any evidence of metastasis or that. So if there is any evidence of metastasis or that, we can discuss the case with the multidisciplinary team.
Okay.
So according to the staging of the tumor, we can manage this prostatic
Yes,
carcinoma.
I have to interrupt you. I'm sorry. The
No
report
problem.
states patient has 9.8 Ng per ml of PSA level. What does this signify? What does this tell you?
Yes, ma'am. Actually, the prostate specific antigen, it's prostate specific, not any disease specific of the prostate. So it can be raised, though it can raise to a mild level in case of benign enlargement of prostate and prostatitis. So there may be a significant overlap in case of prostatic cancer also. So it may be increased in different region also, other than the different scenario also, other than the cancer, like benign enlargement, prostatitis, instrumentation of the prostate after ejaculation, after prostatic massage. So it is prostate
even
specific
after
actually,
vigorous
not cancer
exercise.
specific.
Very good.
Yeah, ma'am.
Okay, can you tell me, in order to do the biopsy, how do you do it?
So biopsy is actually taken. It's a transrectal biopsy is taken like in midline parasagittal plane. At least 12 core needle biopsy, 6 core from the each lobe, ma'am. Actually, so
Okay, plane at the apex, midline,
yeah,
base
ma'am.
bilaterally, yes. And then
Bilaterally, yes, in midline parasagittal
can you
plane.
tell me why multiple biopsies are needed?
Yes, ma'am. Actually, there is often a scanty amount of tissue for the diagnosis. That is the first point. And sometimes there may be some benign mimickers of the cancer. So there may be less adequate sample for the diagnosis also. So sometimes benign tissues are admixed with the malignant tissues, so that can give also the false result. And another one, ma'am, there may be the tissue available for the diagnosis that is pointing towards the malignancy. That may be subtle amount, so we need multiple core biopsy for that, ma'am,
Yes,
for
what is
different
the
region.
sensitivity level of needle biopsy and how could that be improved?
Yes, ma'am. Sensitivity level of needle biopsy about 60 to 70%, ma'am.
No, 30 to 35%. And that can
Okay.
be increased by biopsy of core beyond 6. Okay, can you tell me how would you differentiate between the rectal cells and the prostatic cells in a needle?
Okay, through
Needle
needle biopsy,
biopsy,
you can,
in a needle
yeah, ma'am,
biopsy.
we can go for is it immunohistochemistry of the specimen. For
Yes.
the prostatic tissue, you can go for alpha methyl coenzyme racemase enzyme for as the marker. And in case of rectal carcinoma, we can go for CDX2, CD20 marker,
CD,
ma'am.
yes.
And also carcinoembryonic antigen we can check in the blood ma'am.
Very good. Okay, can you tell me what is the gene mutation involved in the pathogenesis of prostatic cancer?
So actually, ma'am, in case of genetic like familial positive family history or familial deposition, there may be certain genes like HOXB13,
Yes.
MLH1, MSH2, BRCA1 or 2, and in case of most commonly acquired genetic condition for the developing prostatic carcinoma, that may be, ma'am, fusion of the TMPR SS2 ETS oncogene, the mutation of which will cause the inactivation of PI3K or AKT signaling pathway that will cause increased proliferation and growth of the cancer cell.
Okay, good. Okay, can you tell me what are the 3 blood investigations that can be done and can be valuable for this patient?
That may be, ma'am, serum LP level, serum calcium level, serum PSA level.
Okay. Can you tell me how would you mentioned about the grading system? How is this grading system stratified?
Okay, ma'am. Grading actually means the degree of differentiation of tissue. In case of prostatic cancer, the Gleason's grading system is followed. So actually, the most common pattern is preserved as a model for diagnosis. So actually number 1 to 5 is reserved for the most common pattern. The histologist reserved that as a most common pattern, and also then takes the second most common cancer pattern, which is also marked as number 1 to 5. Then together these two grading system is added. So in this grading system, 2 means the most well differentiated tumor and less chance to metastasize, and 10 means most aggressive tumor, more chance of metastasis.
Okay, good. Can you tell me what are the management options available for this patient?
Okay, ma'am. For this patient, I would like to first
Considering its
evaluate.
prostatic carcinoma?
Yeah, ma'am. So I would like to first evaluate if there is any evidence of metastasis to bone or any other organ or not. If there is no evidence of metastasis, we can go for radical prostatectomy followed by chemo or radiotherapy if it is needed. And in case of if there is any evidence of metastasis, we will go for the palliative treatment. First of all, we can go for castration. That can be surgical castration or medical castration, like to do the androgen deprivation. And then we can also go for the hormonal therapy, and there is also chance of doing we can also go for radiotherapy and chemotherapy for this patient if there is any evidence of metastasis.
Okay, can you tell me if a patient undergoes radical prostatectomy, how long would you have to wait till the PSA levels falls below or becomes
Okay,
in a
ma'am.
normal range?
So after an acute insult to the prostate gland, when there is a raised amount of PSA level, we will have to wait to rule out
How long?
At least 6, yes, ma'am. Follow up at least 6 weeks to recheck
Yes,
the PSA
good.
level that it gone or not, ma'am. Yes, it
Yes,
will
4
come
to
to
6.
below detectable level if
Yes.
the whole cancer is removed.
Okay, kindly tell me if after being operated, patient complains of backache, how would you manage the pain of the patient?
So after being operated, if there is a backache, at first I would like to suspect for if there is evidence of bone metastasis or not.
Yes.
So for that pain, I would like to go for radiotherapy specifically for this patient, ma'am.
Okay. What about the any pain medication like
Yes, ma'am.
paracetamol,
Yeah,
NICE
first
or
I'll try
anything?
for definitely WHO analgesic pattern.
Yes.
I'd like to go for first NSAID first or a non-NSAID first. Then I'd like to go for a small, if that is not controlled, I'd like to go for the weak opioids like codeine,
Yes.
dihydrocodeine, and if it is not controlled by that, we'll go for the strong opioid, and if it is not controlled by that, then we can go for radiotherapy, ma'am.
Very good. Excellent. Yes. Thank you.